So we're going to have a look here at some cardiovascular emergencies that you might come across. So the first one, I want to make a distinction between ischemia and infarction. So these are two vocabulary words you might remember from your EMT class. Ischemia is reduced blood flow. So typically we can see ischemia in any part of the body. It commonly happens if there's a blood clot or an air bubble or something that's reducing blood flow in some sort of artery or vein. That's ischemia. Infarction is when there's such a reduced amount of blood flow or such a long period of time that we actually start to see tissue death. And so these are relevant because when we look at an AMI, that's an acute myocardial infarction. So we're going to come back to those words as we talk about angina and a heart attack. So angina is the less serious of the two. Angina is an ischemic event, meaning there's some ischemia, there's some reduced blood flow to the heart tissue. And this could be from a blockage, like we talked about. It could be a blood clot or, again, an air bubble. It could be that there is so much buildup of plaque in the arteries that there's reduced blood flow. Or it could be something temporary where the coronary arteries are spasming and constricting down temporarily to reduce blood flow to the heart. Well, the thing with angina that sets it apart from an acute myocardial infarction is that this blood flow restriction is temporary. Eventually, blood flow is going to be restored to the heart. Otherwise, it would be considered an acute myocardial infarction. So with angina, we usually see this come on as a result of some sort of stressor on the body. It could be physical stress. The person's up doing a lot of activity. They're moving around. It could be an emotional stress, but something is causing that heart to have to work a little bit harder, and suddenly it doesn't have the oxygen and blood supply that it needs. So with angina, we'll have that pain that comes on. But again, it's temporary. So the pain will usually subside within about 30 minutes, especially given a little bit of rest, possibly some nitroglycerin to help get blood flow going to the heart, and that angina will go away. So it's temporary. On the other side, we have acute myocardial infarction, or an AMI. So breaking that word down for what it, or down to what it means. Acute means sudden onset. So this is just something that happens, and it's one event. It's not something that happens over a long period of time, although the damage that leads up to it might be in those kind of things. Myocardial means the heart tissue, and infarction means tissue death. So an acute myocardial infarction means we're having tissue death in the heart that's happening because of a sudden event. So we call that a heart attack in layman's terms, but that's what an AMI is. So this causes permanent damage to the heart because there's such a reduction of blood flow to at least part of the tissues of the heart that those tissues actually start to die. And once that tissue dies, it can't be restored. So that's permanent damage. For someone who's having an AMI, having them rest or taking nitroglycerin does not help. And that pain persists even beyond that 30-minute mark. Now, in a moment, are you going to know if somebody's having an AMI or if they're having angina? There's no way to tell. So we're always going to treat chest pain as though it's a heart attack, err on the side of caution, and treat them as aggressively as we can and get them to the hospital. But just kind of so that you know the difference between these terms. So as we talked about, we can give nitroglycerin and aspirin. So we're going to talk a little bit about those medications. So nitroglycerin works by increasing blood flow to the heart by dilating the coronary arteries. So it makes those arteries bigger so that more blood can get to the heart tissues that are lacking blood flow. So when it does that, that's going to cause some other side effects. It doesn't just dilate the coronary arteries, it dilates all the arteries in the body, or relaxes the arteries and veins of the body. And that's actually going to cause the blood pressure to drop. So one other side effect of that can be a possible headache as the arteries in the brain get larger and there's more blood going to the brain. That can cause a headache as it pushes on the brain tissue. So we see lower blood pressure, the blood pressure is going to drop a little bit. We see a headache. So the contraindications for giving nitroglycerin, if they have a systolic blood pressure below 100 millimeters of mercury and we give nitroglycerin, we know it's going to drop that systolic blood pressure. So if their systolics below 100, we're not going to give that nitroglycerin because it could drop to unsafe levels. Also, if the patient is taking Viagra or Cialis or other erectile dysfunction medications, if they've taken those within the last 24 to 48 hours, they work the same way. They also dilate the blood vessels. So if we combine those with nitroglycerin, that can cause the blood pressure to bottom out even faster. So we do not want to give nitro if they've already taken those medications within the last day or so. The last contraindication that a lot of people forget about is that we can't give nitroglycerin if someone's had a recent head injury. And that's because if they had a head injury and there's a brain bleed, even just a slight little tiny bleed, when we give nitroglycerin, it's going to open up that blood vessel and cause a lot more bleeding. So we can cause, very serious problems with a brain bleed if that's happened. So don't give nitro if they've had a recent head injury that could possibly be a brain bleed. We give nitro sublingually, meaning under the tongue. The tissues under the tongue are thin, meaning that the medication is going to soak through those very quickly and get into the bloodstream a lot more rapidly. When we give that medication, it's usually either a pill or a spray. We'll put it under the tongue, either one pill or one spray, and they will feel it dissolve. They should feel a little bit of a tingling under their tongue. If they don't feel a little bit of a tingling, the medication could have expired or wasn't stored properly. So if you've seen nitroglycerin, you know that it comes in a little tiny bottle, but it's brown, and it's usually covered with cotton. And that's because if nitroglycerin is exposed to sunlight or extreme temperatures, it basically becomes ineffective. So if it's been sitting on the dashboard of their car, it's probably not going to do any good. And when they put it under their tongue, they won't feel that tingling sensation, and they'll know that it's probably not going to work. But we put that under the tongue, we let it dissolve. We're going to recheck that blood pressure. In 5 minutes, if they're still experiencing that chest pain and their systolic blood pressure is still over 100 millimeters of mercury, we can give a second dose. And we can even give a third dose in another 5 minutes. So every 5 minutes, you can give another dose. After 3 doses, call medical control, see if they'll give you permission to give them more. But you just want to keep a really close eye on that systolic blood pressure. Now, when we say a dose, again, that's either one tablet or one spray of the medication. That tablet or that one spray is typically going to be 0.4 milligrams. That's a typical dose of nitroglycerin. Baby aspirin is the other thing we can give. Now, nitro has to be prescribed to the person. So if they're not prescribed nitroglycerin because they've never had a cardiac event before, we can't give them nitroglycerin. But if they have it prescribed, we can assist them with it if our protocols allow. Baby aspirin, on the other hand, does not have to be prescribed. We can actually just give that to the patient, assuming your protocols allow. Same thing. How does it work on the body? It inhibits platelet aggregation, and that's a fancy way of saying it basically makes the blood less sticky. So platelets are the thing that combine to cause clots, to stop bleeding. And so baby aspirin basically makes those blood clots hard to form because those platelets get kind of slimy or less sticky, so they can't stick together. So it may not bust up a clot that already exists, but it'll make that clot a little bit slimy so that additional platelets can't build and at least can't get bigger. Or it may get slimy and slip into a better place. Contraindications for giving baby aspirin, there aren't very many. Basically, if the person has a sensitivity or an allergy to aspirin, obviously we can't give it. And also they're going to have to chew it up and swallow. So they have to be able to protect their own airway. So if they're unresponsive or semi-conscious, just like the nitro, we would not be able to give it because we're going to have to put it in their mouth. The route for baby aspirin, instead of going under the tongue, they're actually going to chew it up and swallow it. And you might be wondering, why are we giving baby aspirin instead of adult aspirin? This is the reason why. Baby aspirin is chewable. And when they chew it up and swallow it, it's going to get into their bloodstream and get digested a lot more quickly. So it'll start to work much faster than giving them an adult aspirin. The doses that you're going to give them for baby aspirin. Each baby aspirin is 81 milligrams. So that does come out to 324 milligrams. If you look at an adult aspirin, you'll notice it's 325 milligrams. So it's essentially the same amount of aspirin. But again, that chewable is going to make it work much faster. So we are going to prefer to give them the baby aspirin. So just make sure you have that and that it's chewable. Okay, moving on to some other cardiovascular emergencies we might come across. Congestive heart failure, commonly called CHF. Now remember, with the blood flow through the body and everything, we have the blood from our body. It returns to the right side of our heart, goes over to the lungs to pick up oxygen, comes back to the left side of our heart, and then goes back out to our body again to then only return back to the right side of the heart. So if the right side of the heart fails, remember, the blood coming to the right side of the heart is coming from the body. So if the right side of the heart is not functioning properly, that blood is going to actually back up into the body. And in that case, we'll see what we call dependent edema, which is basically fluid buildup or swelling in the hands and feet. And it's really, there's extra fluid all in the body, but gravity is going to cause that fluid to go to the lowest points. So we'll see that fluid build up mostly around the hands and feet. We'll see swollen fingers, swollen ankles, things like that. And we'll see dependent edema. If somebody has left-sided heart failure, remember the blood goes right side of the heart, lungs, left side of the heart. So if the left side of the heart is not able to pump blood effectively, it'll oftentimes back up into the actual lungs, which causes them to have pulmonary edema. Now, when that happens, that's what we call congestive heart failure. It's pulmonary edema brought on by congestive heart failure or heart failure. But when we call it congestive heart failure, it means it's in the lungs and it's usually left-sided heart failure, although it could be both sides of the heart are failing. We commonly see this after a heart attack because of that damage that's done to the heart tissue, leaving the heart unable to pump blood effectively. So that fluid has to back up somewhere. And again, a lot of it ends up in the lungs. Just like pulmonary edema, we want to treat this with CPAP. That continuous positive airway pressure is going to push the fluid out of the alveoli, back out into the interstitial space of the lungs, and it's going to force that oxygen through that fluid and into the capillaries, into the bloodstream, instead of just having that oxygen have to passively pass through that fluid or that edema that's in the lungs. So always think of CPAP when somebody has congestive heart failure. If you don't have CPAP within your protocols or you don't have it available to you, whatever oxygen you have, non-rebreather, they might get to the point where they need that BVM as well. Aortic aneurysm. So remember, the aorta is the largest artery in our body. It's the artery that comes off the left ventricle of the heart that basically distributes the blood all around the whole body. Remember that an aneurysm is a weakness in the wall of an artery. So an aortic aneurysm is when we have a weakness in the wall of our aorta. Two things can happen if you have that aortic aneurysm. It's a weakness, it's not a problem yet, but the two things that can happen to it are that it can dissect. We can have a dissecting aortic aneurysm, or we can have a ruptured aortic aneurysm. The dissecting aortic aneurysm are when the layers of the aorta kind of separate. And these aneurysms, it can be in all different parts of the aorta. The aorta kind of comes up and then arches over. So sometimes it'll be in the middle of that arch. Sometimes it'll be lower down in the abdomen, or sometimes it's higher up near, and the patient will feel the pain more in their back, the center of their back. It can be in any part, but that dissection is when the blood actually starts to go between the different layers of the aorta. So it's not leaking out into the body, but it's basically not going through the middle of the aorta. It's going between the layers of the aorta. So when that happens, we might see some really strange things, like blood pressure will be different on the two arms. The patient will often report like a tearing pain. So that blood is basically going to the wrong place, and they're not getting the blood flow that they need. A more serious problem is a ruptured aortic aneurysm, and this is where the aorta actually rips open. And if it's a major aortic aneurysm that ruptures, if it's a huge rupture, they can bleed to death within a matter of seconds of internal bleeding. But either way, if it is survivable, we're going to see shock develop extremely quickly. That pale, cool, clammy skin, rapid heart rate, rapid breathing, cyanosis around the lips and fingertips, all that kind of stuff. If they survive it and they're in those late stages of shock, just treat them for shock by giving them oxygen, laying them supine, keep them warm, get them to the hospital as quickly as you can. There's really nothing we can do in the field other than treat for shock with those typical oxygen, blanket, lay them supine, keep them calm. And for anybody that has this aortic aneurysm, you just want to be really gentle when you move them, because if they're jostled very hard, that could cause it to rip or rip further. Sometimes you'll kind of feel that pulsating mass in the upper abdomen if it's an aneurysm that hasn't quite ruptured yet, or if it's a slow leak. Another thing that can go on with the heart is a dysrhythmia. Sometimes this is also called an arrhythmia. They mean the same thing. They mean the heart is out of rhythm, right? So examples could be premature ventricular contractions. So remember, the heart relaxes and it fills with blood, and then the ventricle squeezes to push that blood out. If the ventricle squeezes before the heart has a chance to fill with blood, the heart's not going to be able to pump as much blood as it normally does. We also might have our typical tachycardia, which means the heart's pumping too fast, or bradycardia, where the heart's pumping too slow. Both of those will cause not enough blood to be pumped through the body, because with tachycardia, again, that heart doesn't really have time to refill with blood between beats. Or with bradycardia, it's just too slow. So the blood flow becomes too slow, and we're not getting enough nutrients delivered around the body. Ventricular tachycardia, sometimes called VTAC, that's when just the ventricles are pumping too fast. So the atria are going slow enough, so the heart's refilling with blood, but when that ventricle's squeezing, the ventricle is not getting a chance to fill with blood before it squeezes. So it's not going to pump enough blood. Ventricular tachycardia can easily deteriorate into ventricular fibrillation, which is where the ventricles are not actually pumping anymore. They're no longer contracting. They're just kind of quivering and kind of hanging out, and they're not really distributing that blood through the body. So that one's a very serious one. With all these dysrhythmias, you're probably going to notice that their pulse is either really fast, really slow, or not a steady rhythm. It's out of rhythm. And if you notice that irregular rhythm, you really need to get that patient on a 12 lead. Try to send that 12 lead off to the hospital so they can see what's going on, or get an ALS provider on scene. Basically, be prepared that you might have to do CPR, because if this deteriorates into VFib, they're going to go into cardiac arrest and they will need CPR right away. Hypertensive emergencies. So remember, hypertension means high blood pressure. Typically, if you're talking to your family doctor about healthy blood pressure, we're looking for that top number, or that systolic blood pressure, to be between 90 to 130. They might even say up to 140 is okay. That's your everyday blood pressure. You're sitting in the doctor's office, relaxed, they take your blood pressure. You want it to be below 130, 140 at most. But you were just in a car accident. You don't, maybe you're in pain. You're worried about, how you're going to pay for the ambulance. You're worried about how you're going to get a new car, or who's going to pick your kids up from school, or all these things that are going on. Your blood pressure is not going to be that same reading that you get in a doctor's office. Your blood pressure is going to be a little bit elevated. So if you're on an emergency scene and somebody has a systolic blood pressure of 150, I'm not concerned. I'm not stressed out. If it stays that way for the whole call, I might tell them to go talk to their family doctor, but in the moment, it's not a big deal. A hypertensive emergency is when that systolic blood pressure is greater than 180. When it's higher than 180, I'm like, this is a ticking time bomb. At any minute, we can have a problem here. This is basically like you take that cheap garden hose from the dollar store and you hook it up to a high pressure hydrant. That thing is going to rupture somewhere. We just don't know where. So I'm concerned. I want to get them straight to the hospital. The symptoms of that hypertension are going to be a sudden severe headache. They can even have pulmonary edema, because that extra pressure is going to push that fluid out of the arteries and into different places, one of those being the lungs. And again, I'm concerned about a lot of things that can happen, but my primary concerns are a stroke or an aneurysm, that blood vessel rupturing open into the brain, or in the aorta, or wherever, rupturing open where it can actually be life-threatening. Okay, the last thing we're going to talk about for cardiovascular emergencies is just be aware you might come across a patient who has an implanted pacemaker or defibrillator. What these do is basically keep the heart in rhythm. The pacemaker just sends the signal to tell the heart when to beat to keep it in a regular rhythm. The defibrillator monitors the heart, and if it gets out of rhythm, it'll actually deliver a shock to get it back in rhythm, the same way that an AED works. Somebody might have just a pacemaker, they might have just a defibrillator implanted, or they might have a combination pacemaker defibrillator. All three of those are common, all the different variations. So if somebody has an implanted pacemaker or defibrillator, you'll see it. It's just going to be right under the skin. It basically looks like an alien implant, and it's commonly placed right under the clavicle. Just make sure when you place AED pads, they're at least 1 inch away. Other than that, the only thing you need to know about the pacemaker or defibrillator is make sure you report that they do have that to the hospital when you're dropping off your patient. Other than that, it's not really going to affect our care very much. The other thing you might come across that's going to be a lot more obvious and may have a bigger effect on our care is a defibrillator vest. So sometimes while patients are waiting to get that defibrillator implanted, an internal defibrillator, they'll actually wear an external vest that they put directly on their skin underneath their clothes. It looks kind of like basically a bulletproof vest, and it has electrodes built into it, and it constantly monitors their heart rhythm. And it works just like an AED. If you can imagine wearing around an AED 24/7, that's what it's doing. It's monitoring their heart. If they get out of rhythm, it's really bizarre. It's just like a regular AED. It'll actually talk out loud. It'll say stand clear, shocking patient, and then it'll deliver a shock. So if they have it on and you're doing CPR and it's not in your way, just leave it on. And when that thing says stand clear, make sure you're listening and make sure you stand clear. If it malfunctions, I have heard of this happening where the person sitting there is talking to you. They're clearly not in cardiac arrest and it's delivering shocks. Or if it gets in the way of you can't get your good high quality chest compressions because it's preventing you from doing that. Either of those cases, you should remove the defibrillator vest. Before you remove it, just make sure you unplug it. That'll prevent you from having the chance of being shocked in case something goes wrong. So that's what I have for you for cardiovascular emergencies. We'll see you in the next video. Thank you.